I'm afraid you get a bit of me, anyway, I'm a vitreoretinal surgeon, but I also do the adult intraocular tumours for New Zealand. But we're a small country, so it's really only part-time. I would like to talk about the management of ocular metastatic disease. And of course, the most common site for metastases is the uveal tract because it's highly vascular. The vast majority are in the choroid and almost half in the macula. So our candidates, when they come to our final exam, usually quote this study by the Shields in Philadelphia when asked as to the relative frequency of different primary tumour sites, and they say the most common are the breast, then the lung. However, you've got to consider where the study was done, and it's going to vary by region. I mean, even in other parts of the same country, for instance, in the southeast, where smoking is more common, lung cancer predominates. And of course, when stratified by gender, clearly breast cancer is not going to be the most common cancer among men, although it can occur and is associated with a higher chance of metastatic disease. So many patients with uveal metastases are asymptomatic, although the most common symptom is blur, followed by photopsia and pain. Pain's not that common, but it's very rare in other ocular tumours. Many don't present, of course, because they've got metastatic disease elsewhere and they've got other concerns that are greater than just having blurred vision. Generally, metastatic tumours are yellow, although there are a few that are typically orange, and metastatic melanoma is usually brown. On ultrasound, they're often of a kind of medium to low echogenicity, relatively low and flat, often associated with a large serous detachment, although by no means always, of course. There are also changes you can see on OCT and fundus autofluorescence, but while they've been described, they're not diagnostic, and they're certainly not diagnostic of the site of the primary tumour, so it really doesn't help that much. Of course, in the differential diagnosis of a uveal metastasis, you've got to think, particularly in New Zealand, of a non-pigmented nevus or melanoma. I guess uveal melanoma is less common in India, although I do see it's on the program, because they can be non-pigmented as well. And in fact, 70% of all non-pigmented tumours are said to be melanocytic. There are also quite a few rare, benign, non-pigmented tumours as well, although some not so rare, such as osteomas. And lymphocytic tumours can also look very similar. The second most common site of metastasis is the orbit, with the other sites extremely rare. In the orbit, breast again is said to be the most common primary site, although again the prevalence depends on geographical location. For instance, quite a high chance of it being hepatocellular carcinoma has been reported from Egypt because apparently hepatitis A is very common there. Orbital tumours usually arise in the orbital fat or rectus muscles and present as a solid but usually somewhat poorly circumscribed mass. Bilateral disease is actually rare. Bony erosion is unusual, except that prostatic carcinoma tends to metastasize to the bone. I remember from when I was a trainee being taught that breast cancer often causes enophthalmos, and due to contraction of the stromal tissues and a reduction in the orbital fat. Actually, this is not the most common presentation of this disease, and the term that I learned, scurus, also no longer appears in the breast pathology literature, and therefore perhaps should no longer be used. And here is the relative frequency of the various symptoms and signs of orbital metastases, with proptosis clearly being the most common, followed by visual loss and strabismus. So the workup of a patient with a suspected metastasis depends, of course, on whether the primary is known or unknown. The latter need much more in the way of workup, of course. The former, though, you should always tell their oncologist that they've got it, because it may change, they may need to restage them systemically. But 1/3 do have no known primary diagnosis, and these patients clearly need a thorough workup. The most obvious question to ask, of course, is, are you a smoker? Generally, I do a PET scan on these patients, although in a smoker I might start with a CT chest. So how do we save the eye? Sorry about the New Zealander making the catch. But our goal, of course, depends on the patient's systemic status and the treatment burden, as these sick patients may not wish to have a lot of additional treatment for the small amount of time they have left. However, even a patient with only a short time to live doesn't really like to go blind. Often, of course, the systemic treatment that a patient is on will also treat the metastases, and because of the choroid's fenestrated epithelium and high blood flow, there is often good drug penetration. And of course, there are many of these treatments which a patient may go through and beyond, which may be used by themselves in combination or in combination with a local treatment. However, the definitive local treatment really is external beam radiotherapy. The main thing about this is to make sure there's no CNS disease at the same time, because you want synchronized therapy. It's not good to irradiate the eye and a bit of the brain and then irradiate the brain again. Higher doses are used for short-term palliation where side effects are unlikely due to the patient's life expectancy. So here's a patient who had lung carcinoma metastatic to the choroid. You can see 18 months later, so they do live a while. There's little left superiorly, bar an atrophic scar. Inferiorly, the tumours are much reduced in thickness and the serous detachment is gone, and you're really just left with a pile of soot. I've also found photodynamic therapy very useful, although Visudyne is hard to get hold of, I think, worldwide at the moment. However, it is a quick and easy treatment when it is available, and you can just do it on the spot. You don't have to wait for them to be booked in for radiotherapy. So here's a 42-year-old patient with lung metastasis just before he had PDT, and here he is a month later looking a lot better, although his vision didn't improve much. You can also use brachytherapy and shrinks metastases very effectively, but of course it's a bit more invasive. Other local treatment options can also be used, such as transpupillary thermotherapy. I've used TTT, but not as a treatment for metastatic disease, so I don't have experience with these. The ocular prognosis depends on the location, size, and number of metastases, of course. I mean, if the tumour is already infiltrated under the macula, the vision's likely to be lost and remain lost. But small extrafoveal tumours can do very well. How does it all work out in the end? Well, overall, of course, the main determinant of longevity is the type of underlying tumour. Just to finish off, well, to cover all the bases, retinal metastases are very rare. However, vitreous metastases are becoming more common, especially in patients with metastatic cutaneous melanoma, because the checkpoint inhibitors that they now put these people on treat this disease very efficaciously elsewhere, but because of the eye's status as immunologically privileged site, they may not be able to get into the vitreous, which makes it difficult sometimes to convince the oncologist that they've still got anywhere. And people are still experimenting with what the right treatment is for these, but a vitrectomy or external beam or maybe intravitreal Malphilan or some of these in combination may be the treatments. So just finish off with a few photos of New Zealand.